painting project.
Right here, and then there's also the television over here, which theoretically should show the same thing.
Yes. Yes, I did. Thank you very much. Okay. All right. My name's Doug Adkins. I'm the executive director at Dayspring Village up in Hilliard. And I'm just going to put these down here. I don't think I'll need these too much. And I would like to thank Mike Hayes and Mr. Chairman, and I'd like to say hello to my colleague Lauren Taylor from Starting Point. We work very closely all the time. And I'd also like to recognize your in-house expert, Deweese Ogden, who is probably one of the most dedicated people on transportation. And of course, Mr. Chairman, strong leadership is without question essential to problem solving, and you have, in my case, I think probably one of the strongest leaders that transportation disadvantage has had in Nassau County for many years. And so, it's a great credit to have somebody of Mike's caliber here at the helm, driving the bus, so to speak. And he's lucky to have you, Mr. Chairman, at the helm, driving this. So, but what I'm here to talk about is...
I'm sorry, but if you see me driving the bus, something is going on.
I understand. And same for me. If you see me driving the bus, you need to have me pulled over because I am not your bus driver. So I'm here to talk a little bit about Dayspring Village. We have two facilities. We have Dayspring Senior Living, which is our new campus up in Hilliard that is dedicated to seniors. That facility, that campus opened in 2016 in November. That will grow up to 180 beds when it's fully operational. We're at 32 beds now. We're planning to open the second building. We'll start construction. It's been authorized, it's been funded, and I think we'll be having a groundbreaking soon. Hopefully when the governor's schedule clears up, we'll be doing a groundbreaking soon with that. And we're hoping to get that underway in probably about 10 months. Building 2 will be opening up on that campus. We'll be opening an adult daycare program down in Hilliard, so we're expanding our senior platform pretty aggressively up in that part of Nassau County. But our mental health facility is a 128-bed facility up in Hilliard. We specialize in schizophrenia and schizoaffective disorders. Some of you are familiar with what we do. We've been there for 30 years. For 30 years we've done this work. We served over 4,000 people in the course of that time. And transportation and mobility is incredibly important to recovery. It's incredibly important. So you have two systems of care. You have the scheduled system of care, and then you have the unscheduled or crisis-driven system of care that drives access to health care. Now, people who live in a facility under Chapter 429 or a nursing home have a special set of civil rights called the Resident Bill of Rights that guarantees them access, undisputed access to services. So, access to adequate and appropriate health care for low-income ALF residents. I want to kind of bring your attention to this because when you look at assisted living facilities that serve low-income low-income residents, we rely upon the Medicaid transportation system to ensure access to adequate and appropriate health care. That's the scheduled system of care. And I can tell you, I spoke with Mike Hayes and I said, listen, I'm a Nassau County guy. I'm committed to our local Nassau County providers. My new senior living facility was designed by people in Nassau County, built by people in Nassau County, and is occupied by people in Nassau County. I can tell you, I didn't use anybody out of Orlando. I didn't use the Jacksonville guys. We used people out of Nassau County. But the reality is our providers are important in Nassau County because keeping the Medicaid dollars in Nassau County is important because of what Mike talked about, surplus income. Surplus revenue into our not-for-profits is very important because it's used for other things. It's used to enhance services in other ways. And so, as Mike pointed out, that surplus revenue comes in very handy when you guys are looking at how do we handle other issues. Every not-for-profit is faced with the same challenge. And there's nothing wrong with surplus income. Now, I'm a private sector guy. I call it profit. Not-for-profits call it surplus income. All the same thing. But the reality is it's very important how you run your business. So residents at our facility, if you have income of $911 or below, you're eligible for full Medicaid benefits. 911 or below. We can turn on the Medicaid lights. We can drive Medicaid transportation. That lights up the Medicaid eligibility standard. If you're inside the ALF. Now, if you're living outside the ALF, you're going to have to be meeting that SSI standard. You're going to have to be meeting some other standard. But when you're living inside the ALF at $911, we're going to light up the full array of Medicaid benefits. A lot of people don't know that. But this is a missed opportunity. A lot of times gets missed because those eligibility benefits don't get turned on. We turn those benefits on. We make sure that the provider knows this person's Medicaid eligible. You need to make sure that you're switching from non-sponsored transportation to sponsored transportation. This is a Medicaid compensable claim that you need to be submitting to. You need to be picking this person up. The non-sponsored population, however, must rely on non-sponsored transportation. This has always been a tricky issue. I just had a lady come to my facility last week. Her name is Justina. She flew here from Texas. I have one of the largest clozapine programs in the Southeast United States. Clozapine, the psychopharmacology of treating schizophrenia, the #1 drug for the treatment of schizophrenia is clozapine. We have one of the largest programs in the Southeast United States. And so we do a lot of work with it. Lauren can tell you this is an issue we talk about every week, how we're dealing with these patients on this medication. But the reality is that this lady flew all the way from Texas about her brother, who's 58 years old. Her sisters, her and her sisters have been taking care of this young man all of these years. She has cancer. She's going to die in the next year. Her biggest concern is, where will my brother be before I die? Will he be safe? She has searched far and wide to look for the best place where her brother can be safe. And that's why she wanted to come to Nassau. She wanted to come here to put her brother with us. Unfortunately, there's no room at the end. She has cancer. She's going to be, and she's a veteran. She served in Iraq. She's a wartime veteran. Her sister's a wartime veteran. Her other sister's a wartime veteran. And they want to take care of their brother. And they've been taking care of their brother, but they can't do it any longer. This is the story I hear time and time again. I have mothers who walk into my office and lock the door, and they're 80 years old, and they come and look at me and say, "You must promise me you will take care of my son." And so this is a tragedy that's unfolding right before my eyes that I see every day. A heart-wrenching tragedy. And let me tell you the sad part. I have to cap the number of beds that I allocate to the non-sponsored people. It's capped at my facility. I could have open beds at my facility, and you have a son who has SSDI and is non-sponsored, and there's no room at the end because I can't meet his needs, because I can't transport that person, I can't move that person. We have to cap access because it is so difficult, so expensive, and so complex to meet a person's needs who does not fall within the Medicaid system. What you don't know about the public mental health system, it does not function well outside the non-sponsored dollars. It is complex. It's way more complex to meet their needs. The dollars don't drive well, okay, in terms of providing services. So let me give you a little bit of after-hours transportation, because unscheduled access to care happens. So after hours care, let me just walk you through this. Residents go to the hospital. They have a right to go to the hospital. So we'll do our best to redirect them to the scheduled system of care. Lauren gets these calls, and residents will say, well, I still want to go. So Century Ambulance ran 206 trips down to the hospital emergency room, non-emergency transportation trips to the ER for assessment and evaluation. When you say, I have a change in condition, my big toe hurts, my side hurts, or whatever, I want to go get assessed or evaluated, or there's a change in condition. So a couple of ways you get to the hospital. The doctor says, send my patient to the hospital. The mental health provider says, send the patient to the hospital. The facility could be a facility-driven event. We want to get the assessment. We need to have the assessment within a certain time frame. It has to be timely. 6 to 8 hours, you're going to have to get it within a time frame. Or the patient comes up and says, you know what? I don't care what anybody says. I'm just like every other American. I want to go to the emergency room. And so what happens is you have to send them. So this is the data from last year. 206 trips were transferred down to the hospital for assessment and evaluation. Century ran 206, Nassau County Fire Rescue ran 57. That's how many went down. So, now, when they get down to the ER, most of it's catch and release. Most of it's assessment, evaluation, treatment, stabilization, and then they're coming back. Now, getting them back is pretty sticky when you don't have Medicaid. Because if you don't have Medicaid, you got a problem. So what's driving these trips? Most of them are, as I talked about, mental health. Aging is an issue, rising acuity. Okay, rising acuity with the mental health population. Did you know the average life expectancy of a person with schizophrenia in this country is between 58 and 64? 58 and 64. That's the average life expectancy in this country of a person with schizophrenia. They don't live long lives. When you think about it, this is a kind of a pretty scary proposition. So what happens is acuity starts ramping up. We start dealing with a lot of complexity. So when the tobacco tax rolled out, everybody was, oh great, let's go tack $1 on, and I want to get that extra $1. Well, you know what the extra $1 did? The mentally ill who cannot afford the filtered tobacco bore the burden of that extra $1, because most people with mental illness have a huge addiction to nicotine products. And so they bore the burden of that extra $1, and that extra $1 forced them to start smoking what? Cigar tobacco. More carcinogenic, more harmful. And that more carcinogenic cigar tobacco has led to what? Increasing rates of COPD, increasing respiratory problems, which is translated into what? Increasing trips to the emergency room. So when you look at it, mental illness also masks symptoms of pain. People with cancer, for instance, can be walking around. Schizophrenia fragments those symptoms, and you don't pick up on the pain symptoms. So also residents have increased levels of symptoms of psych and medical issues, and so these are things that sort of drive it up. So according to ACA, in the Winter Medicaid Managed Care Report, you should look at this in terms of preventable conditions. This is very important information. COPD in Region 4, that's right here where we're at. COPD led the pack of conditions in our area, followed by symptoms and heart failure. This is what was driving the ER visits. Schizophrenia was the top, potentially preventable in readmission at 24% in our emergency rooms. Schizophrenia was the #1 diagnosis for United Healthcare, which is our health plan out there in Hilliard. And by the way, that they do a fabulous job. United Healthcare is probably the best healthcare plan. I think everybody, at least in my view, has done a fabulous job. Region 4, schizophrenia is 24% of the preventable hospitalizations. So we have 26 current non-sponsored residents at our facility. So we have a 128-bed facility. And that's a CAPA that I have. And this is a problem. So I can't get them back from the emergency room. Years ago, Council on Aging had an after-hour service. They had an after-hour service that would allow us to send somebody down and pick them up and get them back to the facility safely and appropriately. So if people had seizure medications, had diabetes, and needed to have their blood sugar checked in a timely way, they weren't sitting in the emergency room. And Ms. Ogden knows this. I used to routinely get onto the Medicaid director in Tallahassee for 10 years. And we worked to change that, didn't we, Ms. DeWeese? And it took us 10 years, but we got the rules changed to urgent care transportation in the Medicaid program. And Medicaid program now requires you to pick up that person within 2 hours. Or within 2 hours, call the health plan, and the health plan then has to start making arrangements. And the planning process is engaged, and we have some predictability about when that person is going to get picked up. So let me tell you about Florida assisted living facilities right now. They're in crisis. For the facilities that are serving the middle income and lower income, you lost 969 state licensed limited mental health ALF beds last year alone. That's on top of the 2,000 that were lost since 2014. So Parkland, The shootings that you're starting to see, the increased rate of violence, let me tell you about violence. Violence is 11% on average. People with schizophrenia, that number jumps to 25% when they're not being cared for or supervised. It drops to 9% when somebody's paying attention to them and providing them access to care. That's just an absolute fact. So when you have a look at the average rate that we're receiving, it's $12.25 a day. There's not a whole lot of revenue there, but when you look at income erosion, when people are at the hospital, when they're on PASS and you cannot submit to Medicaid, the actual claims data shows it's $5.76 a day. Not a lot of revenue that is flowing into these facilities for access to care. State long-term care program, not a lot's changed there either. There's a huge problem there. The average cost of care in Northeast Florida right now, according to Genworth's cost of care studies, $3,500 in Northeast Florida. You've got a huge emerging problem with dementia that's unfolding here in Nassau County. I mean, an absolute crisis that's unfolding. And you have, emerging issues around how you're transporting and how you're caring for that population and how those needs are being met. So, Florida's new regulations have impacted those small facilities. 50% of ALFs in Florida are small. The small facilities are not large. There was a 17% property tax increase right here in Nassau County that affected us, I know. The nursing homes received new money for the generators. ALFs received zero. That's why you have a 17% non-compliance rate with the generator rule. My two facilities are compliant. I can't speak for everybody else, but we are compliant. But the reality is loads of people could not comply with this, particularly the minority access facilities could not comply with it. They're just simply going away. We're simply going to lose the minority access facilities, and that is going to create an absolute train wreck in terms of how we're going to care for those populations. Last year, liability insurance rates went up 20 to 50% in Florida, and utilities are seeking new dollars for grid hardening because they feel like that's justified, but there's no new dollars to pay for the cost of care. So training is key to the frontline workers. We do a lot of aggressive training, food safety, a whole range of things out there. But Florida statute is 487.0155. And this is what I wanted to talk to you about. We're looking at wanting to amend this section of the law. And let me tell you why. We believe the Transportation Disadvantaged Service Plan should be amended to include a provision that would ask for language to comport with the same planning standard for the Medicaid population that you have for the non-sponsored population. These populations are similarly situated, and right now, this is what you have in the current plan, you have 800 number, but these populations are similarly situated. You have a Medicaid recipient living in the assisted living facility. You have a non-Medicaid person living in the same facility. One person can access urgent care transportation when they're ready for discharge from the hospital. The other person cannot. That's called disparity. It's a civil rights issue. And I hate to put it in those terms, but plain and simple, that's exactly what it is. We have to have, from a planning standpoint, from an organization standpoint, equal treatment. Those populations have to be treated equally in terms of getting them back from the emergency room on the same footing. That's without question, as far as I'm concerned, a constitutional duty that we have. And so I think it starts with a Transportation Disadvantaged Service Plan. I've highlighted for you here, this is exactly what the plan says. And I think these are the sections of the plan that can be improved. So, life-sustaining medical, and I think these are the right priorities. I think the priorities are absolutely correct. But I think these are areas where we can make changes. So I think there is, when you have a look at right now, this is what the solution would be, is I think for a long time, we had this access to service in Nassau County. We don't have it now. And what I would offer is that I think the legislature is right now having a surplus, robust time over in Tallahassee. And I think right now Nassau County should have an opportunity to simply say, look, access to after-hours transportation, the ability or to contract for that service and to make that service available ought to be a priority so that people who live in these facilities have equal access, because the health plans have to provide that 2-hour window and respond to these people. And these are people that have high acuity. So let me tell you what can happen in an emergency room when somebody with schizophrenia who also has diabetes is not getting their medication in a timely way because we can't get them out of the emergency room. The amount of disruptive effect that you can have in an emergency room, you could put that whole place upside down with about 150 people sitting in that ER in about, I don't know, about 2 minutes. It wouldn't take very long at all to have a person who's just becoming that unstable as a result of just not receiving the care they need. So what's really important from the ER staff and the social workers is they want to know exactly how quickly, when they're ready for discharge, getting them back to the facility. And that's good for them, it's good for us, it's good for everybody, really, because the timeliness factor becomes very important in terms of the transfer. So I believe that there's an opportunity this year that the legislature's meeting, they're deciding what this budget should look like. Nassau County historically has really never got its sort of fair share of the pie, if you will. And there's a lot of smart people over there, smarter than I am. But the reality is that these types of priorities, particularly the acuity level, when you think about the acuity level, have to be a priority. However that's contracted out, or however the CTC decides to coordinate that, we have to elevate that discussion in these particular individuals to a higher level of conversation. Because when you think about people with schizophrenia, when you think about people with schizoaffective disorders, particularly those who do not have Medicaid transportation, the biggest challenge is Lauren can tell me, Doug, I want you to send the patient down to the ER. Question is, okay, how are we getting them back? And how are we going to coordinate that? Because that becomes a challenge. It becomes a barrier to getting that person to care. So then we're worried about how long they're going to be sitting there. How's that all going to work out? And so I believe that there's some solutions. I believe we've got some wonderful planners in this state. I think we have a great budget environment right now to prioritize this through. And I just think this is, for the rural counties particularly, I think this is a priority issue that should be addressed. And I understand, look, there's limitations to what you can do. But when you think about the facilities, in the licensed facilities and in the acuity that they're experiencing, I think this is where you have to sort of say, look, if you have an urgent care transportation request coming out of the emergency room, coming out of the hospital, we've got to get them back. Now, if they're up in a hospital bed, they can schedule that with Mike's office the very next day, and they do a fabulous job. Let me tell you something. These guys have improved the service, incredibly so. And that's one of the reasons why I've directed all of our transportation through our local hometown provider, because I want to see our local hometown provider be incredibly successful, because that's what's important to Nassau County, is to have an incredibly successful provider system. But at the end of the day, and the reason to have that is to make sure that our residents and our folks who live here in this county can be successful, because when they're successful, our citizens are successful. And that's what's important to Nassau County. So, Mr. Chairman, thank you for the opportunity to be here, and with that, I'll entertain any questions you may have.
Okay, are there any questions for Mr. Adkins on his presentation? All right.
Nothing?
Thank you.
Okay, all right. Thank you for your time.
Doug, I do have a comment, please.
Oh, please.
How are you getting these folks back now? It's a late afternoon, late evening, weekend discharges. How are they getting back to basically go to family?
Let me tell you what happens. So you get a call from the nurse at the emergency room, the staff do, and they start off yelling at the staff, sometimes screaming at them, and just, really having, it's abusive. And so what happens is they end up calling me, and they say, well, Doug, what am I supposed to do? And I said, well, there's some real competent, compassionate people down in the social service department. And what happens is they will ask, particularly Baptist. Baptist is the only one that will do this. is they have a cab voucher that they'll issue in order to facilitate that. But it places a significant burden on that hospital, that they then call me into the 13th floor in front of their corporate people, and then I get berated before the corporate people routinely about why is Nassau County unable, willing to take care of these type of issues. And so I kind of walk them through, when they decide to take, at the hospital level, there is a contract that they sign with CMS, et cetera, and I walk them through the whole dynamic of that relationship, okay? So there is, but when you go to Shands, if the patient decides to tell the ambulance driver, take me to Shands, I like UF Health. You know what's going to happen at UF Health, Mike? The answer is flat no. You wait till 8 o'clock in the morning when COA wakes up. If they're not waking up until Monday, well, you know what? Find yourself a little campy corner down there at Shands, and I guess you'll get home Monday afternoon. Or you better call somebody, because we're not paying for cab vouchers like Baptist does. Memorial Hospital, same thing. St. Vincent, same thing. You have one hospital that will do this. And so, unfortunately, we're leaning on the goodwill of other people. We're leaning on the charity and the goodwill of other people. So what happens is, you can't take care of, so the consequence then is I can't take care of when your brother, your cousin who has SSDI and is limited in their income resources, no room at the end. Can't take care of it. Because if they have that need, you can't send them, you can't, because you can't get them back. You don't have an ability to make that happen because you have to depend upon those relationships or goodwill of somebody acting in a charitable manner, because unfortunately, there's no other way. And that's just not a way in this day and hour, in this century, for us to say, well, that's what we do. That's how we ought to do. That's how we ought to manage these situations. That to me is not a system. So I think, unfortunately, this has just been on my radar list for some years now. It's now bubbled to the top. But the reality is that it's something that should be rectified. I mean, the TD Commission themselves should have corrected this. The transportation disadvantage plans, quite frankly, structurally should address this in the transportation disadvantage plans. And that's where it should be addressed, in my view. The coordinating boards have the power to do whatever they want to do. But I also think, recognizing that there's a fiscal, impact to, contract that, I also think it creates the basis upon which the CTC organizations could say, look, to the legislator, which we have a very fine legislator who's in a position to do something about those circumstances, and to say, look, there's an obligation here. In fact, there's a legal obligation under the 14th Constitutional Amendment to make sure, under the Equal Protection Clause, to say these people will be treated equally and not in a disparate manner. And so I think in that fashion, I think it would behoove them to make sure that equal access is provided, particularly for people that are similarly situated. Now, I can't say that set of circumstances exist for all people, because all people are different, but certainly people who live in the same facility, they're similarly situated, they would meet that definition. So I think they should be treated equally because of that. So I think there's a basis upon which for the CTCs to make that request and to say, look, I think there's a reasonable basis upon which to make the request for additional funding to accommodate that issue.
Well, I appreciate that, Doug. Really for us, it comes down to funding. Because we're in the business of doing what you're asking for. We would like to do more of it. But we just don't have not enough funding to be open on during evenings and weekends and those other times when people get sick. You get sick, People get sick on Christmas Day, just like they get, today.
That's true.
And, yeah, but, there's just not enough, there's no funding to do that. There's no money.
Well,
When
well,
we used to have the old Medicaid
well,
model,
well,
I get calls at 3 in the morning.
Well, the dollars exist within the healthcare budget. It's a matter of how they decide to appropriate the healthcare budget. So there's two ways to go about this. You can either have the the legislature can appropriate it. The legislature can amend the statute to simply say, well, here's how the TD, Transportation Disadvantaged Service Plan should function. You can have a federal judge say, look, you've got a disparity issue, you need to cure the disparity issue, okay? Because you cannot have a disparate situation. You cannot have disparity that permeates that circumstance. And so once you're on notice about disparity, you must cure disparity. You cannot allow disparity to be persistent and recurring, because the continued recurring act of discrimination, is just not possible, particularly if they are both being funded by the state of Florida, and the state of Florida has set policy and says policy-wise, for the Medicaid person, we're going to create the 2-hour window. But for the non-Medicaid person, well, it's a whole different standard for you because you're a different person. No, you're the same person. You're still a Floridian. And so that the whole equal protection clause comes into effect that says not similarly situated populations, equal protection, you're going to be treated the same. So the legislature has to then cure it and say, well, if you have a funding issue, they've got to then rise to that occasion. That's the reasonable expectation of your legislature to say, okay, we now have this circumstance, you guys need to respond. So I think that's a reasonable request. Certainly I talked to the transportation chairman over in the Senate about that, Senator Lee, I think, he certainly understands it, so it's a matter of how much is it in their budget, where is it in their budget, how do you get, the number of trips we're talking about, it's not that many. I mean, because the reality is what we try to work towards is scheduled systems of care, not crisis-driven systems of care. Last year at Dayspring, I have 128 mental health patients. We had 18 big wrecks the whole year. 18. Not that many. So the reality is that the system works very hard to provide care through scheduled systems of care, not crisis-driven systems of care. And so that's why you look at the volume of Medicaid trips you're running, that's reflective of why that system is running the way it is. And so, and there's a deliberate cap on the number of non-Medicaid recipients, okay? Because of the complexity associated with transporting those people to the ER and back from the ER, okay? And so the reality is that we understand the complexity of the issue, we understand the fiscal impact of the issue, we understand how it plays out. But the reality is that you can't have a persistent situation that allows for disparity to occur, and that's why I'm saying is we have to cure that. However we cure that, we have to cure it. And we have to find a way to cure that, because you cannot have two policies that allow for treatment to be provided, to allow for two different populations similarly situated to be treated differently. That's not possible. Not in this country. Other countries, yes, but not this way. Okay, so that's what I'm saying is I think is, so I don't anticipate there's going to be any kind of solution today or any kind of solution maybe next week or even maybe within the year, but this is a problem, it's an issue. We used to have after-hours transportation in this county. That used to be something we did for a number of years. Deweese knows that. I mean, Connie Huffstetler was here. We used to do that. And I think this is something we need to figure out, what is our path to go back to how we used to do that. And then we need to figure out what's that going to cost us, and then where do we get the dollars. This is the best budget environment we've had in a long, long time. So right now is a good time to ask. Any other questions?
Doug, are you asking this board to do something, or?
The request is we need to cure the disparity, and I think the action of the board would be to petition, I think, the legislators and to obviously go to their planners and to go to their partners and say, you know, listen, what's the path forward? I think obviously there are a number of ways to get there. I think you can contract for a solution. I think there's a number of ways to get there. But I think we need to have, and I think it needs to be on the board's radar list. I think there needs to be a formulated solution, and I think we need to come up with some sort of plan. And I think when we get there, I think it'll help solve the problem, and we can then say, look, we're taking care of this. We're dealing with this issue. It's no longer an issue. People are, you know, we're acting responsibly in terms of getting this issue addressed.
So the solution that was on the last page of your PowerPoint, to edit or to include the language on the plan, is that something?
Yeah, you can do that. You can amend the Transportation Disadvantaged Service Plan. You could do that.
Would that be the most expeditious way?
That certainly creates that from a planning standpoint. But, you know, as Mike kind of pointed out, you know, from an appropriation standpoint, it shifts dollars in appropriations. But, you know, you've got right now they're putting together the budget. And so you can write a letter to the chair of the committee, you can write a letter to the senators and to the representative and say, listen, you know, we need to make sure that we can address these type of needs. And we need to make sure that you guys are providing the resources, particularly to the rural counties. Because the rural counties have always had the toughest time. It's not such a big issue in the metropolitan areas, but it is a big issue in the rural counties. Because we have large geographic distance. You look at the geographic distance of Nassau County, geographically, it is a exponentially larger burden. Yes, sir.
The overall cost before, when we used to provide it, is when they didn't abide by the law, just to fill you in. And one of the reasons it was cut back is you had 18 trips, but you're asking us to provide 365 evening plus 52 additional weekend days for somebody on standby.
You can contract it.
Huh?
You can contract to have a contractor on call.
Okay. Your own organization could probably do that too, but, you know, that would resolve your immediate issue.
I just got done walking you through what is probably a catastrophic meltdown within what's happening. But, you know, the reality of it is no, that's not possible. So, I mean, what I can do is I can start discharging all the non-sponsored people.
I understand
And
where you're
so-
coming from, but also the reality of our side is it takes a while first to train a person to be able to meet the requirements.
Mm-hmm.
Now I have to staff somebody to be able to even get down there when it's just an hour ride just to your facility
Sure.
to, from like this side. If I have somebody up there, okay, it's a shorter time, but it's an hour ride from your facility down to there.
No, it's 36 minutes to the ER.
After hours, yeah, maybe. I'm
Yeah.
also thinking rush hour traffic.
No, it's 36 minutes,
Okay.
38 minutes, and if you go to Baptist North, it's 24
But how
minutes.
many times did it happen? But, you know, unfortunately, the overall cost is we have to have somebody ready 24/7.
The way it used to work is they would have somebody on call. If the person was needed, they were called, okay? It was as simple,
Correct, but we were also breaking the law back then because no one was really tracking how many hours somebody was on the road. Right now, the only way I could provide that is have somebody work all day, and now you're throwing this on, and now we're actually breaking the law with how many hours somebody's authorized to drive per day.
You can have a subcontractor as a CTC coordinator. You can subcontract the service if you choose, which is how the CTC in Jacksonville does it, if you choose. or you can provide it yourself if you choose. You have options. You don't have just one option, you have multiple options. And so this is kind of this is sort of a narrowly defined
They,
obligation.
they can afford that because they have over 100
Correct.
buses per day
Correct.
on the
Well,
road.
they don't provide any
They,
direct
they don't do,
transportation.
they don't
Correct.
do
They
after
pay
hours,
us.
they don't do after hours. They contract their CTC because they don't provide their own CTC. They pay MV, a contractor, to do their
OMV's doing
CTC.
it?
Yes, but they don't do after hours. They got away from any Medicaid type stuff a long time ago, and they won't,
What are they doing with the, non-sponsored then?
they do normal daytime service.
So they have.
Dialysis, they don't do
So
nighttime.
they have the same problem? They have the same disparity problem?
But it's this, I don't know, there's been a request and there's not, again,
Well, you know what?
again,
You
it's
know,
a funding
I serve on
issue.
several of the trade associations, so I can assure you that the operators in Duval County have the same heartburn. They have the same grievance, the same concern.
But
So I
like,
appreciate you informing me,
right,
because the reality is that the administrators of those facilities are faced with the same exact challenge. Trust me, I hear about this recurringly. And so you cannot have disparity. Other countries you could do this, not in this country.
I can tell you in Duval County, they have the issue of people can't get to work after midnight. We dealt with that when we worked there because the buses
But we're
stopped.
talking about healthcare.
Well, I mean, people don't work, they
We're
can't get
talking
healthcare.
about people's health. That is the highest priority of these dollars. TD dollars are prioritized. The highest purpose of these dollars is people's health. And if we don't get that, and if we don't get that straight, then we're really upside down. So I would say that, somehow we have to cure the problem.
Well, it sounds to me like we're not gonna solve the problem.
Not-
today.
not today.
I certainly appreciate you bringing
Yes,
it
sir,
to
we
us,
will.
but
Right.
it sounds like we need a lot more vetting of the
Exactly.
situation before.
I think
you
your
know,
representative over here had a question.
Yes, sir.
Maybe I'm asking out of ignorance here, because
Sure.
I don't know the system, but when we're talking about a disparity between sponsored and non-sponsored, is the expectation from the state or ever who, because we're saying you don't have the money to provide this after-hours service, is the expectation that somebody who is non-sponsored has an income level high enough that they're expected to contribute their own dollars to their health care?
So these are people who are going to meet a certain poverty level. In order to qualify for non-sponsored, I think, Mike, you guys have a kind of a threshold for non-sponsored.
It could be income or other reasons, disability, age,
Right.
things like that, yeah.
So
I'm just asking,
Right.
is the situation arising because the thresholds are set wrong, or is the expectation from people from the outside looking in saying, this person who's non-sponsored has more income, so they should be able, or you should be able to charge them something that
Right.
supplements you maintaining a driver and a vehicle,
Right.
or
Right.
being able to
And
contract
trust me,
it?
they can't even afford to pay the rent. So if you can't afford to pay the rent, so the option for me is really, we've been steadily easing back on the non-sponsored people. You saw the numbers, 26. I have a 128 bed facility. We have pared back the number of non-sponsored people for this exact reason. Okay, so we've sort of done our part to sort of pare back the burden so that the system of care that we offer allows our providers to drive up their surplus Medicaid earnings, okay? To make sure that the system is functional, to make sure access to care is being driven, because Medicaid drives the community-based system. It really does. Medicare does not provide access to transportation. Medicare is hospital-based. It provides access to care inside a hospital. It was designed for that. But the reality is Medicaid is what drives the community, access to community-based care. But when you don't have Medicaid, it is really complicated to get you or your family member access to care. It is the most complicated situation in terms of care coordination that we're going to face. And it's not impossible. I mean, we navigate it. Lauren and I work these cases all the time. But it takes more time, more effort, more resources to navigate those cases than any other case that we deal with. And so what's happening, though, is the reduction in access. And when you look at the patients that are ending up in the commissioner's jail system, that have problems, you start asking, well, how many of those people are non-Medicaid? A rising percentage of them are non-Medicaid, because it's difficult to plan and provide access to care. It's just a fact, you know, and so the truth is, you know, providing access to care becomes difficult in serving this population, and we have to find a way. And so, you know, my issue is when we're dealing with people with complex conditions, they have to go to the ER and we have to get them back. All I'm saying is we have to find some sort of logical way to make that happen. And so I think this board has the power to sort of say, look, we can amend our transportation disadvantage service plan, we can petition the legislature, we can do some things in our role as a CTC to advocate for this issue. And that's the only thing I'm saying. Okay? So I appreciate your time, and I appreciate the good work you do. You have some wonderful people here, so I appreciate the opportunity to come and speak to you. Any other questions? Thank you, Chairman.
Thank you. So Marshall, maybe a step forward here. I know, are you the staff member for all the other counties in Northeast Florida for this?
Everything, the 6 counties, not including Duval.
Okay, so maybe a good thing would be just to ask them if they have a similar challenge.
Sure.
And then we find out if it's a Nassau County problem or a regional problem.
Okay.
Does anyone else have any other suggestions?
Well, one thing I would look for is donations to buy the taxi ships. So, because a transit agency can't do that so much, but it could be done through a different, because of the 1490 rules. That's what they were trying to explain. For them to hire a contractor, that contractor has to also do drug and alcohol, all the training that, and so then you're spending a lot of money for that type of a contractor. But if there's some way to find donations or ways to get funds to have taxi vouchers for those clients, much cheaper, easier way of doing it.
And I think you said Baptist does it now anyway, so
Maybe
we can
just a
figure out.
couple of years.
Okay.
Why would it be exclusive to Baptist?